utero. So it goes from the mom to the fetus, the IGD. Okay. It's usually transferred again during the third trimester. So if you think about it, again, those babies will really miss out on this iron, and glucose. The babies were born earlier, don't have this capacity.
Oh my god, is this online? Like, this ought to be online. Do you hear my laptop? It's mad loud, right? Which is crazy, bro.
Is this still the same content?
Shut up.
IgM antibodies are produced in response to blood antigens. They're negative inherent organisms and viruses in the expecting mother. IgM does not normally cross the placenta. So IgG does, IgM does not. It's actually produced by the fetus beginning at 10 to 15 weeks. Elevated levels at first may indicate that there was some kind of leak, and maybe there was a problem, between levels 12 and baby 12 and baby requiring some kind of virus. Rather than just know that the IgM does not cross the placenta. The baby, the fetus itself produces it. The IgG crosses the placenta.
IgG?
And then the IgA immunoglobulin, this will detect provide detection on screen sepsis and respiratory tract infections.
Do you know if this background's online?
Tract infections and eyes. Again, this does not cross the
Does your pen?
That is not
Your pen?
used by the fetus in utero. But the colostrum, the first 3 days of that breast milk is called colostrum, is high in IgA immunoglobulin. So that's one of the reasons we like to encourage
Come on.
breastfeed the first couple of days because the colostrum is helping for the baby. Help the baby get these antibodies. So IgA, breast milk, IgG,
I'm just gonna go shopping.
mother, IgM, the baby. And this is all in chapter 17.
What the? Oh.
Okay. I'm going to start a little bit with this chapter, but I'm going to move on to this. This is chapter 18.
It's not China. It's not China. It's not China. It's not Mulan. It's not. You be sipping on my coffee also?
So this is more of anything that you want.
One iced coffee.
Okay. So this is newborn assessment. We're looking for signs that maybe there's a problem with the baby's respiratory system. So again, this is signs of respiratory distress in the fetus, in the newborn mother. So signs indicating the problem that nasal clearing we talked about, right? The nose is carrying more oxygen. The intercostal or sternal area, chest contractions. Okay, so again, the baby's kind of breathe in more oxygen. Grunting on exhalation, so you'll get this little discrete sound that the baby can make. And again, it's this is just part of trying to get more oxygen into its lungs. Sometimes you'll see generalized cyanosis. Sometimes you'll see a cyanosis just around the baby's mouth area. Okay? And sometimes you'll see babies look baby has facial bruising, because sometimes when you look at the baby who has facial bruising, you don't know that. You think the baby's being cyanotic, okay? So there are a lot of times they'll say facial bruising so that they know that. A flaccid body posture means that they're not flexed. Abnormal breath sounds, abnormal respiratory rate usually is elevated, or abnormal heart sounds and abnormal newborn size. Okay, so some of that would be part of it, and again, it could be babies more early. Okay. Initial assessment of a newborn, as we said, is the APGAR score. It's done in 1 minute and 5 minutes. The baby's weight and length is also performed, but even before the weight and length, uses the vital signs as well. Okay. The big thing about vital signs is they want you, the NICU nurse told me that when the baby's quiet, the first vital sign you're supposed to take on the baby is the respiratory rate.
Yes.
Okay, this is from a NICU nurse. So take the respiratory rate. Again, a lot of times people have a hard time hearing it, so try to listen at different parts, so the little sounds, they breathe. Or watch the rise and fall of their abdomen. Okay, you can count it that way. But really you want to listen to make sure there's no fluid in the lungs also. So you want to get the vital signs on the baby. You want to get, perhaps we'll do the length and weight right after that.
Ow.
So the first thing you do when the baby's quiet, respiratory.
Oh.
Okay. The second thing you do is what? The baby's quiet, heart rate. Okay. The last thing you want to do is the temperature of the baby. That disturbs the baby, makes him quiet a lot of times. So you want to get the other vital signs done prior to that. And then the length and the weight of the baby. There's something called gestational age assessment. Again, I've done it with my students. I don't know, do you get to do anything like that with your babies? With the gestational age valid score? It's fun, isn't it? What did we do? Last week we did, the baby was actually, we got a score of 40.5 and the baby was 40.6, meaning 40 weeks and 6 days. And we got it as 40, I think it was 40.5, meaning 40 weeks and 5 days. So it's a fun thing to do as an estimate, really. You don't always have to do it. They usually do it on babies that have like a discrepancy in their size. And let's say a baby is born 10 pounds or 11 pounds, and it doesn't mean the baby's really, post-term. It can mean the mom was diabetic. So they would look for, even though the baby's big, it might have immature assessments when you look at the baby. And then again, you want to do the real physical assessment of the baby, then the neuromuscular maturity of the baby, and again, my other one. Okay, the APGAR score, A for appearance or color. It's very common for something called acrocyanosis, which means the baby's hands and feet are blue. Okay, there's an immaturity to their circulation at first. The P of the APGAR score is pulse or heart rate. And then G, grimace, reflex irritability, means if they're crying or not crying. A, activity, their muscle tones, are they flexing and extending their arms and legs?
Oh, she had it.
And then R is for respiratory effort, that the baby's respiratory rate is within normal range. But again, if the baby's born and they go through transitional stage, their respiratory rate could be higher. And that they realize that because of the time they're doing it. Okay, APGAR scoring, again, this is just basically looking for 1 minute, 1 full minute heart rate, and how the points are divvied up, okay? So you can take a look at that. Let's see. Color. So you can look, you have that slide. Okay. Vital signs of the newborn. Again, you have to find out the place that you're at, Valley or Hackensack, what they use for normal vital signs. Does anybody know at Hackensack what the baby's temperature they want it to be? Does anybody know what they have there? So, I remember going there a few years ago and sniffing it out. I don't know. All right. Try to find out when you're newborn what they want the range of the baby's temperature to be at Hackensack. Because sometimes they'll say, I Identical time is lower than Valley, and Valley is 97.7. But this is a normal range that you want to have the baby temperature within 97.7 to 99.5. Okay, and then you see 36.5 to 37.5 Celsius. The heart rate or pulse, 120 to 160 beats per minute, can increase during crying or transition when the baby first comes out. Okay. Respiratory rate is 30 to 60 breaths per minute at rest, can increase when the baby is crying. And then the blood pressure is 50 to 75 millimeters of mercury, over 30 to 45 millimeters of mercury. And again, it's interesting because what happens in the baby is each few days, as it gets older, the blood pressure norm will change also. Okay, so it will elevate a little bit. Some terminology: gestational age. A baby is preterm or premature prior to 37 weeks gestation. Term babies are 38 to 42 weeks. Post-term or post-dates after 42 weeks. Post-mature after 42 weeks gestation. And then the placenta, I think I said this to you last week, the placenta starts to age. It gets little infarcts in it, like little plaques in it. So it's not functioning as well as it did prior to 42 weeks. So sometimes you'll see the baby not being perfused enough oxygen and nourishment when they're post-mature, and they start to get long and skinny because they're not being nourished as well, because the placenta's not working. Small for gestational age, appropriate for gestational age, and large for gestational age. Now, I don't know if you have that in peds, but I don't have a little form with me here. Other slide. But they have like a graph where what they'll do is we'll see how many weeks the baby is, and then they'll have that's one part of the graph. The other part would be the different weight of the baby in grams. Okay, so you look at what the baby's age is, and you look what the grams are, and you come up and there's lines that will tell you if the baby is, within the normal weight range for its age. I don't have that. It's the other part of that gestational age assessment. You turn it over, it has like a graph like that. Okay. Physical maturity. These are some of the things that you look at. This is the gestational age assessment. Neuromuscular. Is the following statement true or false? Arm recoil is one measure of assessing a newborn's physical maturity. False. Arm recoil is a measurement of newborn's neuromuscular maturity. An example of an assessment of physical maturity is skin temperature. Skin temperature. Okay. Some of the other things to be aware of: the interventions, immediate newborn period. Of course, the most important thing is maintaining the airway. You want to make sure that you have the identification on the baby and the mother and the father or whoever their significant other is going to be. Okay. Administering the medication, vitamin K, and erythromycin to the eyes. You want to get the measurements on the baby and the skin color. If you take a look at these different types of reflexes, I'm not going to have you memorize when they disappear. Okay? So just let you know, you might have to do that for peds, but you don't have to do that for me when they start to disappear. Okay. Let's go over to the other slide so just a little bit more.
Someone sneezed.
This has more pictures in it as opposed to the slide you have. Okay. Just talk a little bit about that. Okay, here's some of the averages. Okay. And again, when we talk about the general appearance of the baby, they're normally flexed, right? You usually see them flexed. Again, this is right from chapter 18. Okay, so this is just a little bit more detailed than the response we have. The baby's weight and measurement, the average birth rate is about 2,700 grams to 4,000 grams, or 69 pounds. The average length is 50 centimeters or 20 inches. It can range from 19 to 21 inches. Head circumference is 32 to 38 centimeters, and that's 13 to 15 inches. And the chest circumference is usually 12 to 14 inches, but it'll range from 30 to 36 centimeters. The thing about the head circumference is usually about 2 centimeters larger than the chest. The largest part of the body is the head. Okay, so that's normal. My daughter didn't move out. So long.
Jesus.
Did her boyfriend like?
No, you know what? This is the way I always keep my husband. Just pile high.
She sounded so defeated.
Huh?
She sounded so defeated.
And I was supposed to move in yesterday.
Imagine that.
They just moved in Sunday, and then they didn't have to check ready. Didn't go through or whatever.
So they're still moving.
No. So I talked to the woman last night because my daughter got they rented U-Haul to move in yesterday, and the woman says no, the place is not finished being painting, and I'm going to paint it. And I'm like, oh, she's full of it, So I said, give me her. Because I'm going to play my house so badly, I'm going to scream at this woman.
Oh.
Anyway, so I called the woman, and she's like, well, they didn't have a check on Sunday, and they're not a married couple. And I don't know how stable, all this kind of stuff she's saying to me. She goes, so I have other people interested. I said, so when do you plan on telling us this? I was like, right there. I want my chair in my house. You don't know what I'll do. It's just swap. But anyway, so the woman's like, tell them to call me at 6 that I have other people interested. So today it's 6. Put a bunch of my kids' heads and call them. Just kidding.
He's kidding.
Oh.
Oh, stop texting.
Okay, waiting at the door. Take a look.
Are you gonna move in with Kate? When are you and Kate moving in?
They don't lose their heat.
Aww. Look at the baby.
Here how they do
Look at the little
measurement of the
baby.
baby's length. Again, they'll stretch the baby's leg out. Make sure that you get the heel of the baby and the top of the baby's head.
Move your shit, yo.
So,
Move this over there too, man. I'll give you some of my coffee, asshole.
how they do the
Beginning of semester? I bought you coffee.
The chest is right around the nipple area of the baby.
Like you know that?
And if you do, the abdomen is usually around
You put down your Dunkin' Donuts card, and then they would give you free coffee.
No. No. Stop bothering me.
weight gain, birth weight. Oh, okay. Again, this is part of that large for gestational age or small for gestational age that we talked about. Birth weight less than 10% on that graph.
10%.
They might have it in your textbook.
10%.
Chapter 18.
This is useless.
Baby is small gestational age. If it's greater than 90 percentile or outside the normal range, it's considered large gestational age. So the baby is between 10 and 11 and 89. The baby is average or normal gestational age. Newborns usually will lose 5 to 10% of their birth weight in the first few days of life. Okay, so what will happen is, the baby is pooping now for the first time, urinating, and it's like in position with the water, the cells, and moving out the cells, and the baby doing all this pooping and not eating as much as the first day. Sometimes they just required from being born. So it's not abnormal to see the baby after 4 or 5 days of life lose 5 to 10%. They usually will gain the weight back by the 10th day of life. Babies who are breastfed might lose more because they're not getting the milk for about 3 or 4 days. So it's not unusual to see them lose more weight immediately. Okay. So this is taking the baby's temperature at celerity. This is looking at the baby's feet. We're looking here for the sole creases in the baby. That's one of the things that you will see when you do a gestational age assessment on the baby. If the baby has, you know, maybe there's creases, little creases right here, but doesn't seem to have it further down. This is a baby that usually you'll say is a little bit premature. A baby that's mature will have creases all throughout their foot. So gestational age assessment has to do with physical and neuromuscular characteristics. One of the first things that it asks for is the skin texture of the baby. A lot of times we'll say you can see a lot of the veins of the baby, the skin is translucent. It's a premature baby. As the baby is more mature, you're going to see subcutaneous fat and not see as many vessels. Also, mature babies sometimes will see cracking on different parts of their extremities or even abdomen, and that's a sign of prematurity. Okay? The amount of breast tissue that the baby has. Sometimes you'll see a baby that is born with not a lot of breast tissue, and their areola will have a little straight line across, a little stipple, and that's a sign of prematurity. Okay? The more breast tissue the baby has and areola that's raised, the more mature the baby is. It's not uncommon for the baby to be born with engorged looking breasts. And this could be a male or female, and the reason for that is hormones, which sometimes cause the breast tissue to look a little swollen. Okay, so it can be a male and or female can have this. The lugo is the amount of hair the baby has on its shoulders and its back. Another thing that they're looking for is if the baby's totally bald, it's either very premature or it's post-date or mature. Okay, so they develop their hair, so they get hair around 20 some odd weeks in pregnancy, and then they start to lose the hair as they come to term. Okay. The ear, the development of the ear, they're looking for the baby to have well-formed pinna of the ear, and instant recoil. Premature babies don't have a well-formed ear cartilage, okay? And if we try to do the instant recoil, it would stick. The baby's premature ears will stick and it doesn't move them. Sole creases on the baby's foot, again, bald is usually a preterm baby, and if the baby has creases, it's usually a term baby. And then the testicular descent in scrotal male baby, if it's mature, it should have a lot of rugae, which is like the wrinkles in the scrotum, and the testes should be descended. Okay? And that's usually by the time the baby starts 6 weeks. And then with the female, the labial development. This is the breast bud. Okay? And this is breast tissue. Newborn has stippled areola. Okay? This will raise area 25 centimeters. Gestational age on this baby is 38 weeks. The ear form, let's see, when we have some hair on the baby's ear, we should try to see if we can, maybe have instant recoil. Okay, that's a strong baby's ear. Look at how formed it is, okay? And when you see a premature baby, you're not going to see the rounding of the ear like that. You're going to see it not formed. If it's formed, it's not rounded like that. It's also very soft looking feeling. Sole creases, newborn has 2 sole creases on anterior foot. There's the slip field. So this baby's got 35 weeks. Okay, and this baby here is term baby. Okay, so this is a deeper. But this is the scrotum of the male. The premature newborn testes are not within the scrotum, so they don't, it doesn't look full. The scrotum here has two rugae, meaning wrinkles in it. Okay. And the term, okay. See the difference in the scrotum here? Look at how full it looks, and it's wrinkled compared to that one. See that difference? Okay. So this baby here is a baby that is, the testes are fully descended, and the entire surface of the scrotum is covered with rugae or wrinkles. Okay, you all see that? Okay. This is a premature female. Okay. The labia majora does not cover the clitoris on the preterm. So if you see the baby exposed like that, this is a premature baby. Okay, the newborn has a prominent clitoris. The labia majora are widely separated, and the labia minora also. Let's see, this gestational age is anywhere from 30 to 35 weeks. Again, here, we're saying that this is still visible, the labia minora and majora are equally prominent. This baby could be anywhere from 36 to 39 weeks. So this is the stuff that we have just looked at. Okay. Vernix is some of the physical characteristics of the baby. The vernix is that hair that covers the baby. Premature baby. Postpartum baby has very little vernix. Oh, vernix is a white case. Vernix, you ever see a baby born and they have a white under their arms and by the creases of the baby? That's called vernix caseosa. And that covers the baby in utero. When it's, before it comes out, it's covered all with this nice white stuff on it, cheesy kind of stuff. And that protects the baby's skin from becoming waterlogged. Okay, so it's a protective mechanism. But as the baby comes to term, you're going to see none of the vernix on the baby, or sometimes you'll see in the creases of the arms, the neck, by the legs. Okay, you'll see that. Let's see. Talk about the shape of the ear. The neuromuscular maturity in the baby, the posture's flexed. Okay. Square window sign, no one likes to see being done. Here's a baby who's premature, about 31 weeks. See, he's not flexed. His arms aren't flexed up like this, and his legs aren't flexed yet. So that baby is born early. This baby here, let's see what I have for him. Newborn with a strong reflection of the arms and hips and thighs, and he's about 35 weeks old. Okay. And there we go, big chubby bubby, right? He's looking good. He's all flexed up there. Okay, full term and he's
Chubby
flexed.
baby.
Now the square window sign is when you take the baby's wrist and you just sort of gently try to see if it goes against this part of the arm. Okay. This is sort of opposite what you want to think. This is a premature baby. Okay. Premature babies are not able to get their whole hand close to their body like that. So this baby is immature, of 28 to 32 weeks gestation. And here is a baby that has a 30-degree angle there, and it's usually found in babies that are 39 to 40 weeks. And we've done it where the baby's actually is able to touch the other side of the arm. The squat sign, it listed by placing the newborn supine and drawing an arm across the chest towards the baby's opposite shoulder until there's resistance. You want to look and see where the baby's sternum is located, the midline of the baby, and where the elbow is able to go in accordance to the sternum. Okay? If the baby is premature, take a look how the scarf sign is. It's a little, it goes like a scarf around the baby's neck and arm. So there's no resistance is noted until about after 30 weeks. The elbow moves readily past the midline, and so this baby is a premature baby. Oh, there's our chubby boy. He's a big girl, but he's a chubby boy, right? Okay, the elbow is at midline from 36 to 40 feet, so sort of not, it's not getting that right by the sternum there. And then the ones that are, too short, we'll have it, you can't go past this part of the body. Okay, okay, the popliteal angle is a degree of knee flexion. Okay, determined with the newborn flat on his or her back, flexes thighs against the abdomen and chest, and the nurse will place an index finger against the baby's ankle and try to see how much you can get the lower part of the leg to meet resistance. Results will vary from no resistance in a very immature baby or 80 degrees in term. Okay. The heel to ear, this is again the baby flat on the bed, and you're going to try to draw the foot toward the ear, okay, on the same side of the body until resistance is felt. Should allow me to bend during test. Important to hold the buttocks down to keep it from rolling the baby. And here, look at that baby. Heel to ear. That's a premature baby. It's able to take its heel and put it all the way up to the ear. You see that? Okay. So there's no resistance to that baby. Baby that's term, you will see that there is resistance. It can't even, go past 90, 80, 90 degrees. Okay, nursing interventions for the newborn. We all know that's important to maintain their airway. The bulb syringe, okay, when you do a bulb syringe on the baby, it starts to spit up a little bit. You want to put it in the baby's mouth first. You want to go along the sides of the mouth to suction out any kind of mucus or maybe spitting up. So you suction that out, okay, and then sort of squeeze whatever's there, whatever's close by on the baby's, I don't know if they have a habit sex, like that, chucks or something, and then you go to the other side of the baby. You don't want to go straight down because you cause a gag reflex, okay, so you got, one. Then you go from the mouth, you go to the nose. Why the nose second is because if you go to the nose first, whatever's in the baby's mouth, mucus might be startled they can suck it in. So go to the mouth first, then the nose. Okay, ensure proper identification. And then you're going to be giving the prophylactic medication, vitamin K and rituximab, and maintaining the baby's thermoregulation. Basic interventions provide general newborn care, enhance the bonding, assist with the screening tests to make you, promote nutrition, deal with common concerns. A lot of times, especially new parents have a lot of concerns. Prepare for discharge and ensure follow-up care of the baby. So again, your role is very big as far as educating the parents. Okay, something that they have a lot of questions about. There's also pamphlets and booklets. You can give to the parents, so this way they didn't hear what you're saying, they have something to do. So medications, prescribed medications, vitamin K, promotes blood clotting, but increases the synthesis of thrombin by the liver. And this is from the old book. Again, just look up vitamin K and it'll tell you that. Eye prophylaxis, all newborns in the United States receive an installation of prophylactic agents such as erythromycin in their eyes within the first 2 hours of being born. It provides a bactericidal action to prevent gonorrhea and chlamydia, conjunctivitis, which may be passed to the newborn from the mom. And this is given to prevent ophthalmic neonate form, which can cause blindness in the newborn. So the thing they have to remember is, because I get these when I'm doing the quiz with students, I'm noticing some people are saying the erythromycin is given if the mother has chlamydia or gonorrhea. No, it's given to all babies, no matter what the mother's status is. They may not know it when she's giving birth. All babies by law have to have erythromycin in their eyes. You don't know if the mother has any kind of disease at this point, but it doesn't matter. It's state law that they can get given this prophylactic. Again, you can have those parents who don't want anything done, they have to sign something saying against medical advice, okay? Let's see. The prophylactic injection of vitamin K to prevent hemorrhage. Okay, the dose is usually 0.5 and value is 0.5 milligrams. I don't know what the happensack. Usually done within an hour. And the reason for this is the baby's gut does not have bacterial flora in it yet, and the flora will help produce body material in the baby. 0.5. It goes in as an IM injection. Okay, so here's doing that here. Okay, procedure providing K injection in the area for alcohol, dry, onto the tissue of the upper part of the thigh, the vastus lateralis muscle, and quickly insert the needle at 90 degree angle, aspirate and slowly inject the solution to distribute the medication. Remove the needle and gently massage the area. I never like to use an alcohol swab because that person makes it bleed, so I use too much to it. Okay, and this is showing you where the vastus lateralis muscle is. It's interesting, you'll see a lot of times, nursing is enough for nurses even, but the vastus lateralis, okay, so what do we have here? That's the femur, the greater trochanter. Okay, so that's the sciatic nerve, we don't want to hit that. The femoral artery, we don't want to hit that. Okay. And then, so this is the vastus lateralis muscle. It's on the baby's, look towards the side of the baby's thigh. Okay? This is it. I see a lot of times nurses go into the rectus femoris muscle, this big one here. But that's closer towards the different, vein and nerve. So you really want to go in between from the patella to the head of the femur, so in the middle area of the thigh, between these two members. Okay, and it's the outer side of the window. Okay, so with the prophylactic, erythromycin that they use, usually up to an hour or so after birth. This allows for bonding, which is, it feels like they see the mother and father while they're doing that. And again, this is what the erythromycin looks like. It is like a Vaseline, petroleum Vaseline kind of consistency. You don't want to put that silver part into the baby's eye. It's big, you just put on the lower lid of the eye. And then monitoring the baby's temperature, here we have the baby has a little probe on its body. We have little parts. Those little parts. Usually you want to put this probe, it will regulate the baby's temperature depending on what the skin temperature is. You want to put the probe on an area that is not related to any bones. Okay, so sometimes we'll put it over the liver. This one is not on the bone area, so will not pick up the baby's temperature correctly. This is the nurse cleaning the baby's bilateral alveolar femoral arteries for rate and intensity. Okay, so she presses fingers gently at the joint as shown. She should compare the femoral arteries with brachial arteries. Blood pressure, they don't do usual restoration. Common skin variations in newborn, we talked about the vertex speciosa, which is that white cheesy substance that covers the baby in utero, but when the baby's born, it increases and none at all. Okay. Stork bites is the fancy word for it is allergenic nevi, and that is when the baby has redness over by his eyebrows and redness on the baby's eyelid, and sometimes in the nape of the baby's neck. And then Milia is the white, particularly whitehead from the baby's nose or by its chin. Okay. And again, it's blue here. Mongolian spot, it looks like a bruise on the baby's buttocks. Okay, and you can see the dark skin for Asian babies. Erythematoxicum is a newborn rash the baby will have like pustules. Harlequin sign is when the baby is, because of increased circulation, one side of the baby might be white and the other side might be red because of circulation. This baby has an acrocyanosis, meaning that hands and the feet are blue. Erythematoxicum is newborn rash. It's a newborn syndrome reacting to the environment. It will come and go, seen on the face, chest, and back, and good treatment. You may have a white or yellow pustule or a pustule, and it has a red base. Newborn rash. Have you seen sign in babies? You may see newborn rashes like this. This baby sort of food bite. Mushrooms in the face and on the front of the baby. Milia, again, is close to the sebaceous glands. The baby's face here. And white by the nose. Blue by the forehead. And the chin there. Okay, the baby can have that and it will disappear. Okay. One patient thought it was whitehead and so, no! So Milia is exposed sebaceous glands. If you're wearing big white spots in the face, nose and chin and forehead. The clearest spontaneously within the first month. And sometimes you'll see a little white spot in the baby's bum or roof of the mouth of the baby. And again, that is also a sebaceous gland, and it's called Epstein's pearl. Okay, that's in the mouth of the baby, on the gums. You can see from the baby warm, the flies, you see from the mouth. Sebaceous gland doesn't do anything, it goes away. Stork bite is what we said is an intelligent nevi. You see on the particularly fair babies when they cry, you see the redness right between the forehead, over their eyelids, and the back of the baby's neck. And that again, that's here. Okay. Some of the other things, you know, the baby with this. Maybe Mongolian spot. Mongolian spot is this looks like a bruise on the baby's buttocks, the lower back and buttocks. Okay. Yeah, so I know I had it on one of these. Okay, so something called a nevus flammis, which is also called a port wine stain. Again, looking at chapter for these details. It's commonly seen on a newborn's face. Not that common. Well, actually, I don't see it that often. Okay. It is a flat purple red in color. It has like a port wine color, so it's like a rich redness to it. Mature capillaries that are congested and dilated. Does not grow. It is permanent and will not fade. Okay, so if you see a baby with a port wine stain, it's flat, there's no elevation. It's a red color. Okay, it will not get bigger, but it will not disappear. Okay. It's associated with childhood cancers. So if the baby is born with this, you're going to have to monitor the baby closely. This is what it looks like. Okay? So it's not raised, it's red, and as I said, it doesn't get bigger, it stays the same, and again, they have to follow up on the baby if the baby has any kind of cancers related to it. Another type of skin you might see, nevus vascularis, also known as a strawberry mark or a strawberry hemangioma. Okay? It's benign, it's with capillaries, it's raised, rough, dark red, found in the head region several weeks after birth. It can increase in size and number. It's commonly seen in babies that are premature, but it resolves all by itself without treatment. So, strawberry mark. In your textbook, there's a picture of a strawberry mark on the baby. So you can see what it looks like. It's sort of, it's raised, that's the difference. And it's benign, and it disappears by the time the baby is here. That's the difference. So that next time you meet, that much we can use the text. That baby. Okay, so some of the physical characteristics of a newborn. Again, I'm trying to get through this so that next time you can review and get ready to test the following after you know, do that. Okay. As I said, the head is large for the body. The baby might have molding or overlying cranial bones. You feel the baby's head, sometimes you feel a little ridge. That's sort of overriding bones of the baby's head. That's because the baby's head molded because of birth. Okay. And the baby's head will not mold like that. Okay. The fontanelles on the baby is those little soft spots on the baby's head. The anterior fontanelle is shaped like a diamond. Okay. The posterior fontanelle is shaped like a triangle. You're going to have to know this, okay? The anterior fontanelle is diamond-shaped. It closes at about 18 to 24 months. Okay, that's a test question. And then the posterior fontanelle is shaped like a triangle, and it closes in about, I think, between 6 to 8 weeks or 6 to 12 weeks. Okay. So we go up to 12 weeks. And then some other things that you might see on the baby's head. And this is also a test question because you have to know the difference between these two different things that you might find on the baby's head. Okay? One thing is called a cephalohematoma, and another one is called cathepsepticenium. Okay? So, of course, we say cephalohematoma, but we say cathep. Okay? A comparison of what this is. Okay. A cephalohematoma is a collection of blood resulting from ruptured blood vessels, and what happens is usually it's from a birth that maybe they use a vacuum or there's some trauma to the baby's head. Okay. And this is blood that accumulates from blood vessels. Okay. So you think of hematoma, cephalo meaning head, hematoma meaning blood. Okay. So think of that. Cephalo head, hematoma meaning blood. So it's a collection of blood resulting from ruptured blood vessels, and it's located between the cranium, or the cranial bone, usually the parietal, and the periosteum membrane. Okay, so in other words, it's like between really like the skin and the bone of the baby, of the head. Okay, and the big thing about it is blood. Okay, it can be some traumatic birth. It usually shows up within 24 hours of birth, and it takes 2 to 3 weeks to resolve. Okay? So it shows up within 24 hours of birth. It's blood between the skin, the periosteum, and the skull. Okay? Traumatic birth. And the other big thing about it does not cross the suture line of the baby's head. Okay? So let me take a look. See this baby here? Baby has some little the cathep septicemium is occurs when the baby's born, and it's swelling, it's not blood, it's edema in the baby's head. Okay? And it appears right away, and it disappears within 3 days of being born. Again, it could be from the wind of the pushing, it could be just, the baby's head is continuing against the bone or something. So it's swelling, it's not blood. It appears right away, it disappears in 3 days. And the other one was blood and it disappears in 2 to 3 weeks. The big difference between the cathep and the cephalohematoma is that the cathep will cross the suture line of the baby. So, you see this picture here? This is the caput. It's a collection of fluid under the scalp. And the suture line is that sagittal suture line. So when you feel the baby's head, when you're feeling the baby's, when you're feeling the anterior fontanelle, and you go back to the posterior fontanelle, okay, you'll feel a suture line, like a line that you feel the baby's head. If the baby has a hematoma, it will be on one side of the suture line. It will not cross the suture line like this one. It will stay on one side, right there. If the baby has a caput, it will cross the suture line. So the suture line is crossing, the baby is going to cross it. It's almost like a cap on the back of the baby's head, caput. Okay, so it's covering the whole back of the baby's head. So it crosses the suture line, and it resolves in 3 days. So this one here, the caput, remember, okay, you see it right away. It's fluid edema, okay? It crosses the suture line like a cap on the person's head, and it resolves in 3 days. Okay? The hematoma, you see within 24 hours. It's blood. It does not cross the suture line, and it takes 2 to 3 weeks to resolve. So you have to know the difference between the two. But you have to memorize that. Okay, here you go. Which statement best defines a septal hematoma? A, diffuse edema of the skull from compression of local blood vessels. It's present at birth and crosses the suture line. Or the periosteal hemorrhage resulting from a traumatic birth shows up within 24 hours and does not cross the suture line. Which one is it?
B.
Right. What do we finish for now then? Okay. So you have 22 enough to it. Look at my baby. Why are you? Yay. Nothing now. Okay, so anybody going someplace fun on break?
Sadness?
Sadness.
Where you clean your house?
Oh, yeah.
Stuff away from that, right?